Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on the surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. I'm your host, Asif Ilyas. So today I am looking forward to our discussion on the recently published article in SurgiColl titled Volar Locking Plate Fixation of Distal Radius Fractures, a Surgical Technique. Beyond the article, we'll do a deeper dive on some of the latest indications, techniques, pearls, and pitfalls with volar locking plate fixation, probably one of the most common fracture surgeries performed in orthopedic surgery. Today, I'm excited to say that we are joined by Dr. Rick Tosti and Dr. Mike Vosbikian, both old friends and colleagues of mine. Dr. Tosti is the senior author of our paper today. He's also an associate professor of orthopedic surgery and assistant program director of the Hand Surgery Fellowship at the Rothman Institute and Jefferson Medical College in Philadelphia. And Dr. Mike Vosbikian is our guest expert. He's also an expert hand surgeon and is also an associate professor of orthopedic surgery and the program director of the orthopedic surgery residency at Rutgers University in Newark, New Jersey. So thank you guys for joining. I really appreciate it. Before we get started in the article, it's always good to go through a couple of background things just for people to get to know you a little bit. So I'll start with you, Rick. I want to ask you about, since you're our author here, about clinical research. Just share a little bit about what got you inspired in terms of doing clinical research in your practice.
Dr. Asif Ilyas. We're laughing. We've known each other a long time. So I was a medical student, and at that time, you were the program director for the residency, and I was, number one, looking to prove my worth to the program, and number two, somebody had told me that one of the best ways to learn orthopedics was to do research. So the deeper dive you can take, into a specific topic, would not only make you knowledgeable, could also make you an expert, could also make you a thought leader.
Well, I can tell you, Rick, you were always exceptional as a researcher and as a writer. You were head and shoulders above other folks. I'm not just saying that. So if I had any small part of that, I appreciate it. But you definitely can stand on your own 2 feet as a really accomplished researcher, and I mean that. Mike, so let me ask you something. So as an expert in orthopedics and hand surgery, what drew you to your surgical specialty of hand surgery?
Yeah, so similar to Rick, in Jersey way, I'll describe it as it's also your fault. After I fell off the spine train and got picked up by the hand guys, I just really liked it. I liked the mechanics of the hand and wrist. It was more complicated. It made you have to think a lot because everything has an impact on everything else. So the fact that everything was interrelated and every single part has consequences on every other part, I thought was actually fascinating. I also liked plastics a lot. So it was kind of the nice marriage of orthopedics and plastic surgery because the soft tissue angle, the fracture fixation, and it allows you to kind of choose your own adventure and decide what you want to do with skill sets from both sides.
Well, I'm realizing right now that I made a mistake having both of you on together on this. I shouldn't have people I've worked with and trained speaking together on this podcast, but thank you guys both. But kidding aside, I have to say I'm profoundly proud of both you guys, really both exceptional docs and surgeons, and I really appreciate that. So thank you. And thanks for, obviously all the contributions you're doing to the field of surgery, orthopedics, hand surgery, all of it. So one quick fun question before we get into kind of the article we're going to be discussing. What is or what was your most favorite or most hated medical TV show or movie, and why? Who wants to go first? But Mike, why don't you go first?
All right, so favorite, I got to go with Scrubs. I think just unbelievably well written and arguably the most realistic of the culture in the hospital between departments and between people. I think they nailed the relationship spot on. Worst, definitely Grey's Anatomy for a litany of reasons that we don't have time for.
A litany of reasons. I love it. Rick, what do you think?
I'm laughing, Mike. We're just cut from the same cloth. For those that don't know, Mike and I graduated the same year in residency, which means we graduated the same year in medical school. So when we were first year medical students, it was like a feeding frenzy with Grey's Anatomy, which was the worst show ever. I remember the finale of season 1 was the surgical intern went in and cut the heart LVAD wire to the patient that he was in love with, so that he would be close to death, so that he could get a heart transplant, by making his labs worse. Coincidentally, I was learning about LVADs because at that time I actually thought I was going to go into cardiothoracics. So I got really into it, and I realized this was completely on Pluto. I had nothing to do with anything that goes on in the hospital in real life.
That's awesome. Anytime you bring up LVAD, I get like a little bit of a shiver down my spine. Did 3 months of cardiac surgery as an intern, and many a night in heart failure unit with patients with LVADs are failing, the batteries are dying, and you're manually pumping them. That was never a great experience back then. But all right, well, that's fun. Always funny to hear you guys' insight. That's great. All right, so let's talk a little bit about the article here. So Rick, let's start with you. So your article focused on the indication and technique for volar locking plate fixation of distal radius fractures. Again, this is a technique paper. I picked this on purpose. It's not original research, but I thought it'd be nice to highlight a technique paper, and particularly this technique, which is so commonly performed in orthopedics in general. What would you emphasize as some of the best indications and or contraindications? I know they're two completely different topics, but you can take whichever direction you want for volar locking plate fixation of distal radius fractures.
Right. So this is probably one of the more common surgeries that we do. In fact, when this comes up in consultation with patients, I'll say this is actually my favorite operation to do because I think it really does make a difference. It's very satisfying correcting crooked wrists, which gets me to the indications. Basically we have your normal anatomic parameters of looking at radial height, radial inclination, volar tilt, and if you are outside of the norm of those typical parameters, then that would be your traditional indication for operating. You also have emergency situations, one being an open fracture. Another one would be one with a nerve compression. So sometimes if you have a distal radius fracture with very significant displacement, that can physically kink the median nerve and create an emergency situation called acute carpal tunnel syndrome. So that would be, another indication. And then I think the one that's talked about probably least is speediness to return of function. So, I'll have fractures sometimes. They're a little bit on the cusp. They're deformed, but, maybe they could go either way. But you may have somebody who is hemiplegic on one side. They need to use the hand sooner, or they live alone and I just really can't live with a cast. So, I've noticed that they rehab a lot better. They tend to recover much faster, with stabilizing the skeleton. So I think all those things are pertinent in the conversation with the patient when discussing indications.
Mike, building off those comments, what do you see? If you want to highlight like any specific indication, contraindication, really what I really want to ask you as our expert is, what do you see as some of the more common mistakes associated with volar locking plate fixation for distal radius fractures?
Yeah, for sure. And just to underscore what Rick said, I think the patient factor is huge. And the longer I've been in practice, the more I offer people surgery that I may not have 5 or 6 years ago because of the return to work, the return to function, ADLs, people that, can't tolerate a cast, things of that nature. I've gotten a little bit more aggressive, admittedly, for that. I think the biggest things I see as the pitfalls are, I think a lot of people get lulled into a sense of security of you put a volar plate on it and it's going to be fine. And I think that's, in most cases, I think it probably will be, because in reality, it is a very forgiving operation. But I think there are a number of things that are a little bit underappreciated for volar plate fixation. One of which being, a project you and I did with the dorsal distal distance is, not getting your screws in the right place. And I think, the advent of VA being more available has helped with that a lot, because you're not necessarily capitated to the screws being exactly where the plate is telling you. So that gives you a little forgiveness. But I still see, fractures show up, especially for revision second opinions, where those screws are nowhere near the subchondral bone and you see a lot of settling. I think that's one big pitfall. I think the other one is, the plate being a little bit too radial. And I think a lot of that has to do with people's initial exposure. And when that plate's hanging over that radial side, it tends to be a little bit irritating. It's not great for the flexors. It can be very symptomatic, especially in your geriatric kind of skinnier patient that sometimes will be very symptomatic. And I think, a lot of that, again, I think is driven by exposure and the position of your plate. So, one thing to avoid that is when you position your plate, I use that distal ulnar screw as the landmark of where I'm actually going to position the plate, rather than where it is on the shaft or where it sits, next to the joint. I base everything on that distal ulnar screw because I think that's the most important one anyway. Other things, volar ulnar corner escape, I think there's still, despite the literature and how strong it is, I think there's a fair amount of underappreciation of a volar ulnar corner fragment and how important that piece really is. And, not being able to trap it or, kind of being a little gun shy with how distal you're going to put your plate, you can let that thing escape. And, I would think the last thing I could think off the top of my head is not trusting your fixation. So see people come for a second opinion from a therapist or whatever for stiffness. And, you'll ask them, when was your surgery? Okay, how long were you immobilized? And, great fixation, look at the old records, everything looks great. And they're still in a cast for 6 weeks. So, I think that, between the surgical insult and the injury, I think that's a setup for stiffness if you're not letting them move.
Yeah, a lot of stuff to jump off on that to talk about. A couple of things just to add some commentary. We just had fracture conference this morning. One of the things I teach my trainees is that unlike lower extremity fractures, which we cover in conference as well, where we typically go to operative management more often, almost irrespective of fracture type because of the need to mobilize patients, like for example, hip fractures, distal femurs, ankles, etc., or plateaus, I should say. And in contrast, in the upper, it's a combination of radiographic criteria and patient clinical criteria, right? So one can trump the other. There can be patient characteristics that drive surgery, and there can be radiographic characteristics that drive surgery. So that kind of touches on both things that you talked about. And even the radiographic criteria are not hard and written in stone. Volar tilt, radial height, radial inclination, ulnar variance, articular step off, all those come into play. And then you can accept a lot in older folks and a lot less in younger folks. And then there may be patient characteristics in terms of what they do or other injuries or what their needs are, et cetera, and that might drive you one way or the other. So there's a lot of that kind of flexibility. But I want to kind of jump a little bit to the hardware part of things that you touched on, Mike, because I think hardware is so important. I think that these volar locking plates have been really fantastic, and broadly, locking technology has revolutionized our management of periarticular fractures, so distal radius, proximal humerus, distal tibia, proximal tibia, et cetera, and really have changed the game and really have encouraged us to treat these injuries more operatively, like Rick said, because they do so well. But I think the catch in this, and the mistake I often see is, for those less familiar, is how to optimally position the hardware so as to not cause a problem later, because that kind of soft tissue profile being so, kind of intimate around that. Rick, any thoughts on that? Like, so one of the things I'll often see is like plates will be too prominent. You mentioned radial, Mike, could be too distal, too ulnar, bones off, screws are proud. Thoughts on that?
Yeah, so I tend to group like failures into two categories. One is lack of reduction, and one is lack of fixation. So, in order to fit the plate well, you have to have a good reduction first. And we talk about a lot of the parameters on the plate, but it's critical that the articular surface is restored, that the inclination and height are restored, right? Because the plate won't sit in that concavity of the distal radius unless that has been done first. So my first comment would be to make sure that the reduction is perfect or near perfect before placing the plate. And then in terms of technical tips, I usually like to edge the plate along the ulnar side, because as Mike said, as it starts to get more radial, you're getting closer to where the FPL tendon rubs up against the radius. There's a tubercle there. A lot of people don't talk about it much. We usually focus on how distal the plate gets, which is also important. But the radial position of the plate is critical in trying to keep the pressure off of the FPL, which is one of the more commonly ruptured and or irritated tendons with the plate. Now that said, so once I line it on the ulnar side, I'll start to push it distally, but you want to be in that so-called watershed line. So it's where the radius goes from being a concave structure to a convex structure, and you want to be below that. There's been multiple papers written on this, and most of us cite the Surg classification and looking at the plate prominence. Generally speaking, the more distal the plate gets, the more prominent it gets. But also, if the reduction is poor, the plate's also going to look prominent because of that as well. So just to kind of bring this full circle, number one, you have to have a good reduction. Number two, the plate has to sit where it's anatomically designed to sit.
Mike, building off what Rick said, one of the things I see that come up a lot with optimally positioning the hardware is the way the screws lock. So fixed angle, variable angle. And I find it really interesting in this space that we're in with this specific fracture construct that folks are very strongly committed to one camp or the other. So fixed angle screws being just that there are drill guides that go in a specific trajectory and the screws lock in that trajectory. Variable angle or polyaxial, whatever term you want to do, gives you some flexibility. Any thoughts on that? Do you have a strong opinion one way or the other, or what to think about with that, with relative to those two types of plate constructs?
I mean, not necessarily a strong opinion either way. I mean, the only time I'm a little bit dogmatic about is if I'm doing an osteotomy, I want fixed angle because it's a little stronger. And, I'm trying to resist forces, and the contact between the head and the plate is 100% of the circumference. So, that's the one place where I will absolutely go for, fixed angle construct, or fixed angle design. For the rest of them, quite honestly, I do it more by the patient factor. I mean, people's anatomy is always a little bit different. And although the plates are all designed for the same purpose, they all fit a little bit differently. Like certain ones sit a little distal on the ulnar side, certain ones kind of hug the contour of the radial styloid where it's heading more distal. So quite honestly, I'll have a couple available in the sets that we have where I am. And whichever one looks like it's going to fit their anatomy the best is just the plate that gets used, whether it's fixed angle, variable angle. If it fits them better, that's what I'm using.
Rick, I'm curious about your thoughts, but I'd add that I think there's always a little bit of danger with the fixed angles, because if you are a little too radial, too ulnar, too distal, you can't correct, so you can find yourself in some hardware where it shouldn't be, either in the radiocarpal joint or distal radial ulnar joint. And I think that's a little bit of a danger with some of those implants, whereas VA gives you that flexibility to kind of avoid that, and while still giving that locking option. Rick, what do you think?
Yeah, I mean, this is maybe one area where I would see it a little bit differently. I actually really like the variable angle screws because my preference for most fractures is to place the plate in a distal position first. So I like that, and then I use the plate as a reduction tool. Most of these have a built-in volar tilt, so if I can put it near perfect on the distal segment first, I can use the plate to lever the volar tilt back into place. I really like that technique. But sometimes it isn't like quite, right in the center. So having some freedom with the screws helps. I may be very ulnar with it, and you have to be careful because you could have a screw in the DRUJ. And I think most of us are very aware of having a screw in the radiocarpal joint. Often that's very obvious. But the lesser worried one is in the DRUJ, and you have different shapes of that in different people. Some fractures may require the plate to become more ulnar. So I like having the ability to aim it in different directions. Also, it's important to have the screws in a subchondral position. The plate sometimes sits a little, as Mike said, a little bit more distal, a little bit more proximal. So being able to angle them to get the most subchondral position as I possibly can is important. So I actually like that. I guess the caveat is not all the plates are made the same either. I'm not trying to pick on anybody in particular, but the locking mechanism in certain plates is stronger than others. So that may be why some people don't like, the variable angle ones. There are certain brands where the fixed angle version of the plate is much stronger than the variable angle, but there are others where I think the variable angle could be comparable as well. So for me, I like having that choice or that freedom because I may have to tweak it a little bit, in the course of the operation.
Thanks, Mike. Thanks, Rick. I mean, broadly, we're not going to get into specific implants. We want to avoid that. And you guys are doing a great job of not getting into specific implants. But there is a lot of nuance to it. As many as there are, and as much similarity as there are between these various volar locking plates for distal fractures, there's a lot of subtle differences that you guys, with your experienced eyes, can pick up in terms of quality of the plate, contour, thickness of the plate, quality of the locking mechanism, number of locking screws, trajectory of those locking screws, the quality of the drill bits and the drivers, versatility of the plates, plate variety, plate lengths, plate widths that vary, complementary plates, radial plates, dorsal plates, bridge plates, fragment specific plates. So there's a lot of nuance to it, but it's a fun fracture for sure because of their frequency our ability to make people better quickly, people's ability to return to their activities quickly. So it's definitely an interesting fracture, but it's also one because of its frequency. The way you laid it out, Rick, in your paper, and especially the pros and pitfalls section, I think is really helpful. Focusing still on some controversies. Rick, I'll ask you first since I know you've written on this, but what about the PQ? I had this discussion just today. We did a couple disparate fractures, and the resident was asking, what do we do with the pronator quadratus? What do you advise, folks, based on your experience and your understanding of the literature?
Well, I mean, we had done a prospective study on this, looking at a 2-year follow-up in people who had the pronator quadratus repaired versus not, and we did not find that the repair of the PQ had conferred any additional protection. So in my opinion, I don't think it's necessary routinely, particularly if you have a good reduction and a plate that's well positioned. I think the mistake some people make is, let's just say the reduction's not good or the plate position's not good, and like, okay, I'm just going to put some soft tissue over this. That may not necessarily be protective. And there are certainly case reports that have been written showing that the tendons can actually erode right through the PQ and then rupture right over a plate that's malpositioned. So I think it gives people a false sense of security. I'm not sure how much it adds in terms of strength. That's a little bit more controversial, but I think in terms of preventing rupture, in my opinion, I don't think it adds much. And we as I said, we had done a prospective study on it. So,
Mike, do you think about it differently, or do you agree?
No, I 100% agree. I mean, if you're mal-reduced and the plate's sticking up, or your reduction's not ideal, it's going to basically make I call it a PQ decube. It's going to get its way through there at some point, and you're going to put pressure on the tendons. That's not going to hold up. And the other thing is, I mean, I take the PQ down with a bipolar, so it doesn't bleed at the end either. So by the time I've taken it down with a bipolar and it's a little shrunken, a little retracted, even if I wanted to repair it, there's no way. But I'm 100% with Rick. It is not a bulletproof vest for your tendons.
Yeah, fair enough. Mike, let me stick with you because you mentioned rehab and casting afterwards. So I find there's a ton of variability on how people rehab these cases. And as you both mentioned, that one of the beauties of this injury and this fixation that we're talking about, the volar locking plate, is being able to mobilize patients quicker. What's your kind of rehab protocol? How do you advise your patients with these post-op?
So post-op, if it's like a younger person, extra-articular, super good bone, things like that, I'll put them in the ABD splint, which is basically just a couple folded ABDs and an ACE wrap afterwards, and then give them basically a removable wrist splint for comfort, or for kind of a reminder you're not ready yet to be doing all kinds of crazy things. Most people I try to put in a removable wrist splint, I think that, a cast is punitive. I mean, people do not tolerate them well, especially in the summer. It's hot, it's uncomfortable. There's just a lot of issues that can happen with casts. So I try my best to, put people in removable wrist splint, let them move active, passive right out of the gate, unless there's some other instability pattern or DRUJ or something else, obviously I'm worried about. But I try to get them to move as soon as possible.
PT as well?
Yeah, I send a lot of people to OT, probably 2/3, I would guess, half to 2/3.
Rick, do you do anything differently?
I'm very similar to Mike. I think if you trust your fixation, then early motion is not only possible, but it's advantageous. Yes, I have them with a removable splint, but my instructions to them is this is really an advertisement to other people to say, back off. I don't think the splint actually holds anything. I just think it gives them a reminder they have an injury, gives other people a reminder not to bump into them. But for the most part, I say, when you're at home and you're just doing regular things around the house, take the splint off. You can use it for things. But my restrictions are, don't put weight on it and don't lift anything heavier than your iPhone. That seems to be just like one of these metrics people can follow, because everyone's always holding their phone. But those are my instructions roughly for the first month to 6 weeks. And then, once we start to get more bridging, then I allow them to weight bear and essentially move on.
Yeah, that's good. I think we're all on the same page. Mike knows about the soft splint. Using an ABD is nice because it's easy and quick. You take it off first post-op. I think removable splint is nice to do. It's easy. They're comfortable in it. They can take it on and off. I like the term, Mike, that cast is punitive. That's a great way of thinking about it. I definitely agree. I think I don't do PT for a lot of things. I think PT for this is good. Some people fall behind and some people do too much, right? So I feel like to me, PT for this is kind of like bumper bowling. It kind of makes sure that people are where they need to be in terms of not doing too much or too little. Because as you know, people can fall behind and get really stiff and not move, and then other folks are doing too much. So I think that's really helpful. And Rick, I use the cup of coffee technique, nothing heavier than a cup of coffee. Although someone then once asked me, empty cup of coffee or full cup of coffee. So that's, or what size of cup of coffee, how big you go. So I was at a meeting, speaking at a meeting in the Netherlands, an international meeting, and a lot of wide awake hand surgery topics came up in that meeting. And I was really interested to see that a number of doctors overseas are really advocating for wide awake distal radius fracture surgery. Now, we know wide awake hand surgery in general is quite common, and I think it's increasing utilization for what I call the routine or smaller hand surgeries, carpal tunnels, trigger fingers, things like that. But there are folks doing it for distal radius surgery. Curious if you guys have any experience with that or any thoughts on that or what have you, wide awake distal radius fracture surgery with a volar locking plate.
I've done it a couple of times in select people in which the anesthesia risk profile may have been less than desirable, and you're obviously running against the clock with the fracture, and clearly this is something that needed to be corrected. So I've done it a handful of times. It does take longer to do. The patients obviously require a little bit of emotional care. I think when you're doing wide awake surgery like that, it can't be the sort of thing where you're rough or you're rushing. So everything has to be gentle, because people get, I think, more scared than they are in pain more. It does take a lot of local for that surgery, probably somewhere in the upper limit of, what you can put in, somewhere between 40 and 60 cc. I use 1% lidocaine with epinephrine, which seems to do the job. But that's what I would emphasize, is just be very gentle, with your hands, with your technique, because people are probably more scared than they are in pain during the procedure.
That's fair. Mike, any experience or comments on it?
Yeah, I mean, at our place, it's not really an option really to do Volant, but I have a very low threshold to suggest a patient do it under regional. I think for a number of reasons. I think post-op pain control is much better. I think their first 24 hours is markedly different when they've had a regional. But I mean, Volant, unfortunately for us, is not really much of an option.
Can you do a regional? If you're doing the surgery in the main OR, can you do it with a regional and no sedation? So a patient, like say above an ASA 3 that they won't clear, say 4 or 5, that needs fracture surgery, and they're obviously anesthesia are often scared of what to do in that situation. Will they let you do a regional and nothing?
It's a little bit of an uphill battle, but if you have the right person on the right day, it's doable. So you just have to arrange it. You just have to arrange it ahead of time.
Fair enough. We all know what you're talking about. One of my last questions is hardware removal. This is a question that comes up all the time. What do you tell your patients about removal of hardware for these cases, and/or do you have any kind of indications or protocols for hardware removal, if at all?
You go, Mike?
Rick, what did you go?
This is for me. Okay. I think it's a complication that's roughly 1% or less, in the right hands. I do make them aware of the risks and benefits of the surgery, which would include hardware irritation, tendon irritation. There usually is a prodrome of symptoms before that. So if you're paying attention, the patient often has wrist pain. Sometimes it develops into crepitus, which can be felt. Sometimes it develops into like a subtle triggering, which could be confused with a trigger finger or a trigger thumb. It's physically like a divot in the tendon that's triggering over the plate. So the surgeon sees that to be aware and intervenes in time. Hardware removal is very simple. It's usually 10, 15-minute case, and they recover. If it progresses to a tendon rupture, then obviously that's a much bigger thing, because an attritional rupture usually requires a graft, and that's going to be a larger dissection. You require a tendon transfer if you can't do a graft. Clearly, the rehab for something like that would be much longer and more involved. So, my warning to people is listen, pay attention for these usually it's like the last visit I give them. Like, okay, everything looks good. Just in case, you start to feel like odd pain in the wrist or clicking, or something feels like crunchy sandpaper in your wrist. Come on back. Let me take a look at it, before this gets to that point.
Yeah. Mike, anything different or?
No, pretty much the same thing. At the graduation appointment, I basically tell them what you got to look out for in the future. And if that happens, come on back.
Yeah, I'd only add that my threshold has dropped a lot to take out hardware over the years, because the morbidity of tendon rupture is so great. And the morbidity of hardware removal is so low that if people come in with fullness, pain, crepitance, discomfort, again, not right away, later, like beyond 3 to 6 months post-op, I tell them the same. Just keep an eye on that. That's a problem. Don't suffer with that, because it can become a bigger problem. Then you and I all know that it's a big issue now when you're dealing with a tendon rupture, and it's a much harder problem to manage. Let's switch gear. One last question for you guys, and both of you as accomplished surgeons and researchers in this space. I want to ask each of you some future direction for research on this topic of volar locking plate fixation of distal fracture. It's an area of a lot of research every month in the surgical literature, including obviously this journal, but others. There's a lot of work being done in this space. Mike, you want to go first? I know you've done some interesting work in this space, and then Rick, same question for you to follow.
Yeah, I mean, I think a lot in the future, I think, is going to be more on the position of the hardware, especially because, again, with the with the VA technology, you can be a little bit more, aggressive about where you're putting it near the subchondral surface, and exactly the position of the hardware, I think, is going to be something that, more and more we understand better with time. And also, I think and there was a paper on this not that long ago on the dorsal ulnar corner, and I think that's a really underappreciated thing. And I think that because we know the volar ulnar corner is a devastating thing because it falls off and then, you get your lunate facet escape, which is huge, obviously huge problem. I don't think the dorsal ulnar corner gives you the same kind of devastating complication that the escape of the volar does, but I think it leads to long-term ulnar-sided pain. And I think that's the patient that ends up in and out of therapy for months and months and months and months, and they're just not getting better. And I think part of it is that when that dorsal ulnar corner is there, I think that it's leading to either a subtle incongruity in the DRUJ, or the mechanics there are changed because the width of the joint is changed. So I think you get a little bit of shear and slop there that you shouldn't have. So I think that fragment, is going to become more important as our careers advance.
As you understand it better. Okay. Rick, what are your thoughts?
I think if you look at the trend of the plates, they will probably continue. I mean, over the years, the plates have become smaller, thinner, machined to be smoother. I think it follows, most natural trends in surgery. We want things to be less invasive. We want things to be with fewer complications, better outcomes. I agree with Mike. I think the volar plate is fantastic for 95% of things. But that 5%, it needs additional attention. It needs additional skill. Dorsal corner is one, volar corner is one, or depressed intra-articular fragments is another. Or you have like mechanisms that just aren't normal, like an avulsion mechanism. That's a whole other problem in of itself. Which, yes, is a distal radius fracture, but it's typically a carpal dislocation with a ligament issue. Which notoriously has poor outcomes no matter what paper you read. So I think there's a lot of work to be done in that space as well.
Yeah, I just echo to kind of round out our discussion here is that we want to make sure that none of us are advocating that the volar locking plate is the fixation strategy for all distal radius fractures. There's probably the majority, because it's so versatile and generally well tolerated if applied well and the fractures reduced well. But there are definitely fracture patterns like radicarpal dislocations, dorsal Bartons, et cetera, that are not it's not the right construct to manage it. And Dr. Tosti's paper does a really nice job going over the indications and contraindications for volar locking plate fixation, and also, like I mentioned, not only the technique but the pearls and pitfalls, which I thought was really high yield and valuable. So we're going to close. And so first of all, Rick, Mike, Dr. Tosti, Dr. Vosbikian, I really want to thank both you guys for your time tonight, the discussion, all your expertise, all your teaching. And then just to close out, at SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down. It allows the authors to maintain the ownership of their work. And most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world, with no requirement to purchase or pay for any subscription. So with that, I would say thank you guys. Thank you for joining us. Until next time.